Thank you. Thank you for inviting me to join this nice gathering. Thank you, Dr. Noura. Thank you, Dr. Najwa. Today I'm going to talk about the PEGylated current stimulating factor and the non-PEGylated current stimulating factor. Just to start, it's refusing. How can I change the screen, please? This one?
Only
yes.
On the yes. Abir will take it.
Yes.
Yes, it's Go ahead.
Sure. Granulocyte colony stimulating factors is an endogenous hematopoietic growth factor, which stimulates proliferation and differentiation of neutrophil precursors, and it increases the survival and activity of mature neutrophils. Of course, we all know this, and we are always having the experience with the regular pegfilgrastim or colony stimulating factor that is short acting. We have to give the injection every day, and we are satisfied, familiar with it. But due to certain situations, people were thinking, why wouldn't we find something that will have a better effect? So this is the consideration of developing long-acting forms of pegfilgrastim. This is the three parameters that people were thinking of while they are thinking of something new to be introduced to the market. So the pegfilgrastim property is subject to renal clearance and neutrophil-mediated clearance. So they are thinking of something that will have elimination or the reduction of the renal clearance to make the drug available in the blood streams for a longer period of time, and allowing circulation of the drug during neutropenia and cleared rapidly when the neutrophils start to recover or catch up, and to provide an effective serum concentration of colony stimulating factor for a complete chemotherapy cycle. For the efficacy, the pegfilgrastim, we know it's reducing duration of severe neutropenia, reduces febrile neutropenia incidence, reduces infection, reduces hospitalization. So the drug that we are looking for, it's supposed to be equivalent or better than the what pegfilgrastim is giving. Safety, pegfilgrastim is having acceptable safety profile, and we are looking for something that will be the same or with less side effects, mostly the bone pain. There is, and with no increase in the immunogenicity. So the PEGylated therapeutics, when they are thinking, they are want something that will increase the hydrodynamic volume, decrease the reticular endothelial system uptake, reduces the proteolytic degradation, and reduces the immunogenicity. So the solubility will be increased, reduce the kidney clearance, and increase the stability of and the serum half-life. All this will cause what? Enhancement in the therapeutic efficacy. So the recombinant regular human GCSF shows a biphasic removal, as I said, from the blood, and it have a long half-life of 90 to 100 minutes. Removal by neutrophil uptake, proteolytic cleavage, and renal filtration. So we need a repeated injection to keep the level stable in the blood during the neutropenia or febrile neutropenia. And by addition of the polyethylene glycol molecule, which is a large sugar structure, to the regular molecule of GCSF, will double the molecular weight, and from 20 to 39 kilodalton. This PEGylation will decrease the renal clearance, so it will increase the blood half-life up to 62 hours. The rationale of the design, again, PEGylated pegfilgrastim is a 20 kilodalton, as we said, of the pegfilgrastim, added to it the polyethylene glycol, so it will be a big molecule. It will have self-regulating clearance, remains in the circulation during the chemotherapy-induced neutropenia, and eliminated while when the neutrophil starts to recover. Clinical efficacy of it is achieved with a single 6 milligram dose once per chemotherapy cycle. The impact of the PEGylation, the covalent attachment of the PEG is widely used to improve the pharmaceutical properties and therapeutics proteins. It reduces the immunogenicity, and it induces the PEGylation induced immunogenicity reduction must be tested individually patient per patient. You cannot guarantee that it will be for all of everybody. The theoretical concerns of the biology of the GSSF stimulation of the normal hematopoietic progenitor cells. This is the most important one that people are aware and worried about. By using long-acting, the GCSF concurrent with chemotherapy will drive these cells into the S phase, the synthesis phase, and increases their susceptibility to chemotherapy cytotoxic effect. Simultaneous administration of the colony-stimulating factor and the chemotherapy will fail or mitigate chemotherapy-associated myelosuppression. It might cause paradoxical myelosuppression, example of it with the down neuropathy. Significant problem would be with concurrent use of the colony-stimulating factor and chemotherapy, or when the colony-stimulating factor supported chemotherapy protocols with a short interval between the growth factors discontinuation and the subsequent chemotherapy, especially in the short-term chemotherapy cycles. Relevance will be higher with the long-acting because we don't have clear duration of effect of the long-acting growth factors. Overproduction of granulocyte will lead to hyperviscosity of blood vessels, and leukostasis in the small vessels. Compromise organ function by increased accumulation of neutrophil in organs. More severe scenario with the use of long-acting growth factors due to their sustained activity after application. The stimulation of malignant hematopoiesis. The colony-stimulating factor receptors are expressed on the respective cell type, causing direct stimulation of malignant hematopoietic cell and non-hematopoietic malignant cell proliferation. Example of it be small cell lung cancer and the AML. All myeloid leukemia cell lines with neutrophilic phenotype responding to the GCSF. If we give exogenous growth factor, it will enhance the proliferation of primary leukemia cell in almost half of the AML patients. Now, that was a theoretical part. Now to the clinical data. Co-administration of colony-stimulating factor with the S-phase cytostatic chemotherapy can cause a myeloprotective or myelosuppressive effect when given with the growth factor simultaneously. The long-acting dose-dense protocols with short interval between the administration of the cytostatic drugs makes potential positive or negative effects on hematopoiesis, cycling behavior of myeloid progenitor cell with long-acting colony-stimulating factor is unclear and difficult to predict. Retrospective pharmacokinetic analysis of pooled data from 6 studies in patients with various non-myeloid malignancy who received pegfilgrastim, 24 hours after chemotherapy showed that almost all patients, the serum concentration of pegfilgrastim is becoming subtherapeutic by the day 11 or 12 from the injection time. This fact does not exclude the progenitor cell are still cycling until day 14 of the first cycle when chemotherapy is re-administered in a dose-dense protocol with 14 days interval. Bone pain will start 1 to 2 days before the bone marrow starting to release the neutrophils. It occurs in 10 to 40% of cancer patients and up to 80% of the healthy donors. The reason is physical expansion of the bone marrow after growth factor-induced cell proliferation, massive extravasation of cell through the bone vasculature into the general circulation, and direct triggering of nociceptive nerve fiber within affected bone. The bone pain is usually controlled by the NSAID, non-steroidal anti-inflammatories. Acute lung failure observation highlights the increased risk of acute lung injury related to GCSF administration in cancer patients, especially pulmonary toxicity, like bleomycin maybe. Association between peak leukocyte count and pulmonary toxicity, suspect that neutrophil would cause pulmonary toxicity. The growth factors use results in neutrophil increase which may be related to pulmonary side effects. Patients receiving colon stimulating factor due to neutropenia have a high risk of pulmonary complication due to either the chemotherapy itself or the increased risk of infection away from the growth factors. The increased white blood cell count lead to leukocyte aggregation, increased blood viscosity, and consequently the results in stasis in small blood vessels. Massive leukocyte increment are very rare and not accompanied by clinical symptoms. Studies have shown that during neutropenia, until recovery, the neutrophil concentration above 2 nanogram per ml prevail in patients with solid tumor or with leukemia treated with PEGylated G-CSF. This level is the lowest level needed for the protection. The PEGylated growth factors is safe and effective if administered as recommended after chemotherapy within 24 hours and when the leukocytes are still in the normal range. Short-term use in patients with MDS or AML without being on chemotherapy reports showed increase in the blast percentage by addition of the growth factors in patients with overt AML or MDS, while blast excess, and there is no studies on the long-acting ones. Increased cell proliferation increases the opportunity for transformation of normal cell to malignant clones. In meta-analysis, secondary malignancies reported in almost 3.28% of patients versus 3.25% in the control without the growth factor. Risk of AML developed maybe due to the high doses of chemotherapy that was accompanied with the growth factors rather than the growth factor itself. And again, the colon stimulating factor treatment of patients with AML resulted in a better outcome than patients without the growth factors, leading us to the conclusion that the AML induced by colon stimulating factor, but better treatment outcome outweighing the risk, potential risk for the secondary malignancy. There is the worldwide phases 1, 2, and 3 clinical trials with filgrastim in severe chronic neutropenia. International registry have provided information on 420 patients, a cohort of 220 patients with the congenital neutropenia treated with filgrastim for up to 8 years, only 16, which is 7%. Cases of AML or MDS LOLs reported, and there are independent risk factors to put it on the having the MDS or AML. None of these patients with cyclic idiopathic neutropenic development of these things. So there is no relationship between those, our duration of filgrastim, and development of the secondary malignancy AML or MDS. In the severe chronic neutropenic patients, suggesting that the mutation causing the severe chronic neutropenia is responsible for the development of the secondary malignancy and not the growth factor itself. So it should be used, the colon stimulating factor should be used cautiously with the exact correct dose and duration restricted for prevention of neutropenia or infection. And this is the final recommendation according to these phases of trials. So now, if we compare PEGylated filgrastim with short-acting ones, clinical trial data suggest a similar efficacy and safety profile with the PEGylated and the maximum 11 days filgrastim. And based on these convenience and patient adherence, pegfilgrastim may be preferred to the daily filgrastim for prevention of chemotherapy-induced febrile neutropenia, especially in frail and elderly patients. A comparison of both forms of drug was based on 5 clinical trials and suggested that the PEGylated is more effective than the regular one for reducing the risk of febrile neutropenia. No clear consensus whether the PEGylated or the filgrastim is more appropriate for patients experiencing bone marrow. It's the same. And if experience bone pain or any other colon stimulating factor side effects switch from one form to another. And there is no clear consensus was reached on the optimal use of pegfilgrastim in patients with renal impairment, knowing that the pegfilgrastim is neutrophil eliminated more than renally one, so there is no dose adjustment is requested or reported. So according to the treatment type recommendations, pegfilgrastim is not appropriate for weekly chemotherapy because we don't know what level it reaches in the body and what it will affect the, as we said, either it will affect the treatment or will not be effective. Short-acting G-CSF is more appropriate. Pegfilgrastim have been used effectively in patients receiving the twice monthly, the foreign-free chemotherapy regimen, example ARCHOP 14. And in split dose chemotherapy regimen, give the pegfilgrastim 24 hours from the last drug given in the combination. And it is preferred in prevention of chemotherapy-induced neutropenia in palliative and maintenance treatment. And it should be continued throughout all cycles of chemotherapy.
Dr. Haya?
Okay, sure. Filgrastim has more application on patients with multiple myeloma than the pegfilgrastim. Consider filgrastim in newly diagnosed patients. It is preferred for consolidation chemotherapy and patients with lymphoma, CLL, multiple myeloma receiving targeted treatment. Pegfilgrastim or short-acting are all both equally effective, can be used. The efficacy, pegfilgrastim reduced febrile neutropenia in patients with non-myeloid malignancies receiving myelosuppressive chemotherapy. A meta-analysis of clinical studies showed that pegfilgrastim reduces the febrile neutropenia risk to a significant greater extent than filgrastim. It reduces the early mortality incidence during chemotherapy, and it's not approved for stem cell mobilization, although there is reports that it was as effective as the filgrastim. It should be administered, as I said, after 24 hours to avoid the stimulation of proliferating risk of myeloid progenitor cell and the worsening of neutropenia outcome. So the PROS requires just one injection per chemotherapy cycle, and thus superior compliance characteristic in measurement of chemotherapy induced neutropenia. It's safe and effective when administered as recommended. The cons, it's lack of physician control. Once it is injected, there is no control on what will happen. If you overshoot, the neutrophil production will be maximized. Stimulation of normal hematobiotic progenitor cell make more susceptible to chemotherapy cytotoxic effect. Overproduction of granulocyte increase the levels of G-CSF, and stimulation of malignant hematobiosis. Use of long-acting growth factor in dose-dense chemotherapy is not recommended, and it induces acute lung failure, increases the neutrophils, may be related to the pulmonary side effects, and have cytosis. Now, I'll just touch about the febrile neutropenia support during the COVID. Consider using the regimen unlikely to induce febrile neutropenia. Consider expanding the G-CSF indication to lower the risk of febrile neutropenia. Criteria is existing for outpatient oral antibiotics, increase interval between treatment, growth factor support to prevent neutropenia. Consider reducing the dose of treatment if feasible, and delay treatment if possible. Consider support stopping or increasing the interval. Of course, most of it have been introduced or exposed by Dr. Majid. This is just a touch on the recommendation of the ASCO of the white cell use updates. The primary, as we know, is recommended for patients with more than 20% risk of febrile neutropenia due to the patient disease or treatment-related factor, and it's the primary patient receiving dose-dense chemotherapy consider alternative equivalent chemotherapy protocols if available. Secondary is used when patient is experiencing neutropenia from prior cycle, and it should not be used routinely for afebrile neutropenic patient, and also not to be routinely used in adjuvant with antibiotic in febrile neutropenic patient. It should be considered in patients with fever and neutropenia at high risk of infection, have prognostic factors predictor to poor clinical outcomes, and prophylaxis should be done in patients with diffuse large B-cell lymphomas aged 65 and or, especially in R-CHOP, as Dr. Nora said. Pegfilgrastim, all the forms of filgrastim are equally effective and should be used according to the convenience, cost, and clinical situation. And since 2006, there is no updates comparing G-CSF with GM-CSF, so each of them can be used accordingly. Thank you.